Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by Dr. Stuart Ray, a professor in the Division of Infectious Diseases within the Department of Medicine with a secondary appointment in oncology. He also serves as Vice Chair of Medicine for Data Integrity and Analytics and as Assistant Dean for Research. Today, we are discussing the lessons learned thus far from COVID-19 and its future implications. So welcome, Dr. Ray, and thank you so much for joining us today.
Thank you so much for inviting me. I'm very happy to be here.
It has been a hard pushing on 2.5 years for everyone, not just here in the United States, but certainly globally. And COVID-19 pandemic has been certainly life-altering, I think, without any exceptions. It also has changed how we interact with one another in the world. Dr. Ray, is it always good when talking about present and future issues in the case of pandemics for us to also understand what the past has taught us? And can you give our listeners the names of some past pandemics and a little history about them?
Yeah, thanks for asking that question, because when people have said to me, boy, this whole COVID thing is something we've never seen before, I can't help thinking about my arrival at Johns Hopkins 30 years ago at the height of the AIDS epidemic. And I was wearing PPE all day long. We had people dying so rapidly. We had a memorial service every week or two for the patients who died in our care. It was a devastating time with little hope for many people until the end of the 90s when we developed antiretroviral therapy, and suddenly it became, for many people, a manageable disease. It's still a devastating problem, but that was one pandemic that really was striking, and we didn't know about it until 1981, and it's now become a manageable problem for many people. We still have some disparities to address, but that's one. There are lessons from others, though, and when we think back, the influenza pandemics of the 20th century are notable, and many people have made reference to 1918 and subsequent epidemics. But there are others that we should think about. Cholera has gone through 7 pandemics in the past 200 years and has had devastating consequences in many places. And so we saw issues of resources and healthcare, impacts on sanitation. Cholera has had a tremendous impact on society. The bubonic plague, of course, is one that people often cite. It's also sometimes called the Black Death because of the dark lesions that people would develop. And that swept through the population many times in history, with many historical writers talking about it. The word quarantine actually comes from that plague, because ships used to be held offshore for 40 days. And that was the quarantine that resulted in our development of that term. Tuberculosis has been pandemic and is now endemic in many places, but it is a widespread infection that has been very disruptive. And when HIV entered the context, especially in parts of resource-limited settings, tuberculosis really spiked upwards. And so we've seen pandemics interacting in that way. People probably haven't heard often about a disease called epidemic typhus, a rickettsial infection that's spread by lice, and that's had tremendous impacts. And some have said has killed more people than all wars combined. So there's that. And then finally, one that is maybe smoldering in people's consciousness, but has probably been a pandemic that really spiked in the post-Second World War period, was hepatitis C, something that was killing more Americans than AIDS for the past 15 years. And so we have had a series of pandemics, and hepatitis C, as an example, changed a lot of our blood transfusion practices. It's another example of how things have been changed by pandemics.
For this particular pandemic, because of social media existing now in so many forms, everyone obviously is aware of COVID-19, whereas some of these that you cited perfectly that have happened or started in the past perhaps were not as well known only because it wasn't readily available on people's cell phones and apps and iPads and television and everything else. That's for sure. So obviously, we're still dealing with COVID-19, and the situation now looks greatly different than it did the beginning of 2020 when it became classified as a pandemic. But looking back on the past 2 to 2.5 years, what did the beginning of the pandemic teach us about readiness for future pandemics?
The ability to respond to pandemic requires a lot of parts, and some things we had prepared for this pandemic and some things we were poorly prepared. As an example, with our supplies of materials, the little swabs that we use for the NP sampling, the biggest source was in Italy. If you remember, in the early days of the pandemic, Italy was one of the hot spots before the US was, and suddenly we couldn't get those swabs in quantity. And so we had major disruptions in our supply chain. It went to the container ships and the ports. One of the efficiencies of our modern world is centralization and standardization. One of our weaknesses is if we centralize too much, we have single points of failure, and you never know quite what might cause a problem. I've been working on a project, and one of our parts sources was coming out of Russia. You can imagine what it's like to try to do something when a critical element is coming out of Russia, and so that had to be resourced. So I think that we have learned about the fragility of our supply chain, but I'm not sure we have solved all those problems. But there's lessons to be learned. We have seen people in staffing manage shifts because people have had to change roles. In our hospital, we converted a lot of our wards to ICUs, or we moved away from outpatient procedures for a while because so much was shut down and people who would normally work there were working in other wards. So we had disruptions within our health system. But of course, we had lots of exhaustion. We had people worrying about their risk of getting infected at work, absenteeism because of positive tests, whether or not people were sick, and then structural changes where people's whole place of working and style of interacting at home and at work changed. And those are things that everyone's going to be thinking about. We certainly are better at doing remote work than we were before. Things like the technologies for that have also enabled more telemedicine. And I think moving care toward the patient, especially people who have trouble with mobility, that's a real positive. But we need to make sure that we can be fair in the way that care is distributed and that people have access to it. Technology access is not uniform. We've learned about the importance of data. And fortunately, some folks, including Lauren Gardner in our engineering department, really stepped up with developing that COVID dashboard that so many people looked at. And I think a big part of that was their articulating standards for communicating data and for people adopting the standards and making the data available. Obviously, that dashboard could never have been populated if people hadn't put their data in a place where it could be reached. And so the importance of standardizing that and then sharing with standard formats and showing people how it worked. They weren't trying to do a closed shop. The code was available, the data sets were available, so lots of people could see that. That kind of data sharing enabled some predictive modeling. But we also learned that it's awfully hard to predict human behavior. People are reacting to the data, and the data then shift because of people's reaction to it. And so we could predict some things, but some aspects of this were so hard to predict because of herd mentalities that made it hard to do that. And then finally, the central role that research played in innovations, in developing new technologies, in finding ways to use technologies like the underpinnings of the mRNA vaccines that had been developing for a couple of decades, and it enabled us to develop an effective vaccine. The Pfizer, Moderna, and J&J vaccines all use the same spike sequence. And that sequence was based on work that had been done with the MERS coronavirus, the Middle East Respiratory Syndrome coronavirus. And so that was also research that paid off with remarkable speed, really unprecedented.
Additionally, when these vaccines became available and subsequently FDA approved, that the public became untrusting because they're accustomed to a drug, any drug, taking 18 years to be developed. And to do something so quickly made people question, well, how could that happen? Without understanding, they just didn't say, oh, let's make a COVID vaccine, that this has been in the works for several decades. And I wish that the media had done a better job of explaining that and covering that kind of information. I think that it would have provided better trust level of the public if they had done that. And talking about staffing, it was and still is to some degree fascinating that someone would be pulled from one job and they'd be doing a totally different job that they've never done before. And then also those individuals that were working in, particularly in ICUs, whether it be a brand new ICU because it was converted or OR rooms were converted into ICU rooms as well, that compassion fatigue and burnout was a major issue. So we had mental health issues for the staff that were on the front line, per se, dealing with this war against this virus and constantly having to roll with the flow and accept change because we needed to learn a lot about this virus and we learned as we go. It isn't that we can say, oh, this is the one that happened 100 years ago. We knew exactly what to do with it. It was new and fresh out of the box and sneaky. And also, as we know, viruses can do, has the ability to create new variants and will no doubt probably continue to do that because we're not done with it yet. I do think that we have been blessed to have the technology that has been needed in order to do telemedicine and in order to do even keeping up with work in general in businesses or corporations of being able to do it using various platforms like Zoom or others that are similar to it so that the whole world just didn't stop. But that we were able to figure out another way to skin that cat. And now that people are starting to resume going back to work, I think we've got to not let our guard go down too low because we aren't done yet. And I, just as anyone else, and you too, I'm sure, would love to say, we're done, clap your hands, put all of the statistics away. We don't have to count anything anymore. But this is something that basically I think I hope we will learn to live with and always have our guard up, as well as lessons learned that this isn't the only virus that we'll ever be seeing again, that there'll be others out there. But hopefully we will have learned, as you just mentioned, with the supply chain of not putting all of your eggs in that one basket. I too think that people don't understand the supply chain, and the swab is a really good example that you needed a swab. You needed the other ingredients in that kit. You need the box. You need the instructions. You need it in different languages. And these things all may be coming from different places. Plus, it has an expiration date. It isn't like, well, I can keep this for 100 years. And when my great-great-great-grandson needs it, I'll have it in the closet for him. We have to pay attention to how long something has longevity and does not. All of that factors into this. I was saying to someone the other day, I got a wedding invitation, and a gentleman said to me, I don't know why people get all in an uproar and all upset and say how nerve-wracking it is to plan a wedding. It's really simple. You just tell the church when you need the church open. I was like, oh my goodness. He said the bride picks out her dress. She tells the groom what tuxedo pattern she wants. So they all rent them. You hire a DJ. You order some food. I don't know what the big deal is. And my response back to this person, who is a friend of mine, I was tempted to tell him, I'm glad you're not planning a wedding. I said, I'm really glad you were not part of solving the pandemic problem because we would be in dire straits if you were involved with that process. I said, what we do want to do with the wedding is make it look like it was easy. I said, that's what you want to do. You want to make it look like it was easy. But trust me, it isn't. And goodness knows this pandemic challenged us in ways that I don't think anyone could have ever anticipated. And there's other things going on in the world at the same time. It's like when you're diagnosed with cancer, you can't say, okay, I'm putting my life on hold because I can only deal with cancer right now. Everything else is still happening, including other major global activities that can all put giant wrinkles into this process.
Well, if I may, I'm glad you brought up that particular point, because one of the things that I've been seeing on the wards is people whose cancers were not managed well during the pandemic because they just feared coming into the clinic or they couldn't come into the clinic. So there have been devastating impacts on people who weren't healthy enough or had the resources to blithely stay home or whatever. So it's certainly had a different impact on people with different resources, different jobs, different different family structures. And so that's been a really tough part of this for many people, especially parents with young kids, as we've seen in recent months.
And for cancer, those that you say the word cancer and people start shaking, and I've traveled the cancer road personally several times, and so has my husband and both of my parents, that unfortunately consumers will look for an excuse to not get screening done because they're fearful of the results. And so the pandemic was the perfect excuse. Oh, I don't want to go in there. I could come out with COVID, which though is a reality. The fact of the matter is that everyone was being extremely careful in protecting, going back to the Hippocratic Oath, do no harm, of making it as safe as possible, maybe even safer than their own home, so that they would not be having to also worry about getting COVID. And now we're in this catch-up mode with cancer screenings. And we are seeing people diagnosed with later stages, and that means a whole lot more treatment and also a higher mortality, which is incredibly unfortunate. And it skews the statistics as well, because it looks like maybe we solved cancer in 2020 and 2021, and now it's going to look like all hell broke loose in 2022 and 2023. Yeah. So the importance of understanding the various methods of where consumers get their healthcare information is also something important to acknowledge that needs to be addressed in the future. We've been dealing with misinformation and disinformation and people listening to sources that are not credible. They'll listen to their neighbor who has nothing to do with healthcare and will say, if you take, I don't know, some over-the-counter something for allergies, you'll never get COVID. And though initially I was laughing at this kind of craziness, I then realized people were doing it. People were actually taking advice from folks that should not be giving any advice and truly believing it, which I still find incredibly unfortunate. It's been this catch-up that some misinformation will go out there and then credible sources are trying to get in front of that train, but the train has left the station and people are following advice that is not in anyone's best interest. I'm not sure how we can conquer that problem, particularly with social media being more readily available today than ever before, but trying to steer consumers to sources that they can rely on rather than listening to everything and anything and then deciding for themselves with no medical degree. I think I'll take door number 2, right?
It has been hard for people to, maybe this is not a great metaphor, but watching the sausage get made is not necessarily good. And science is a messy business. We start with imperfect understanding and we move toward better understanding over time. Watching that process play out is hard. When the news cycle was slower, there was more time for the consensus to be built before there was spread of a message. And in this rapid cycle, people were watching the incremental process of initially people were dealing with relative shortage of masks and uncertainty based on what little data we had on that about whether masks would be effective with this particular virus. And then we learned a lot. And the problem is that there's a memory for those early messages that were informed by prior knowledge. And then with new knowledge, we had new understanding. And it's funny, I've been spending day after day with people with COVID not catching it. And that's because I know my mask works well. I know that they do provide a lot of protection, but it's amazing. There's still a lot of doubt about that. And that's just one example of many where we really need to have trusted institutions. When I say institution, I'm not sure what those need to be, but we need to find a place where we're all able to believe that the process there is sufficiently deliberate and trustworthy that we can believe what we hear, or at least we can weigh that against other sources. I think you're right that it's too much of a level playing field for people who are misinforming and people who are truly constructively trying to inform. It's a tough time right now.
You mentioned about masks. A mask is not a mask is not a mask.
Yes.
I think has been a very big problem.
Yes.
And continues to be that people are putting a scarf over their face and say, I wore a mask and I got infected. How's that possible? So making sure that people understand what kind of mask to be wearing and how to wear it properly.
Yes.
I told my husband, I want to be the mask police because I can make a fortune if I were the mask police and just hand out fines left and right for people that are wearing it below their nose, which really makes me crazy, or even below their chin. I don't know if they think their chin is going to catch something. Very strange. It goes back to that accurate information and making sure that people are following accurate and reliable sources. I would even like to see a discontinuation of the sales of some masks that I've seen in catalogs and such, that just in looking at them, I know they're not going to cover the face properly. And they call them designer masks, right? They've got flowers on them or a face on them or who knows what's on them. And it's like, I appreciate that you want to be a fashion statement, but this is not the time. This is just not the time. So another important lesson that COVID-19 also highlighted was the complexity of health disparities. That is something that not just for this virus or a future pandemic, but for healthcare in general, for us to really tackle health disparities and figure out how to get our arms around this so that it does not result in deaths. Frankly, it should not be that because someone does not have access to care or lives in a poor environment that they miss out and subsequently end up, in many cases, losing their life. In many of those situations, we are probably underreporting the number of people who actually have died of COVID because they died at home, whether the family knew or figured out that was COVID or not, or was it a heart attack or a stroke or who knows. That statistic was not captured as to what the cause of death was. Though we've recently heard that we're beyond 1 million deaths for the United States, we know that that number is much greater than the number that's currently being reported.
And local policies had a big impact on that because in some places people died and nobody did a test. And so you just didn't know. And of course, now that we have less formal testing, that may be even more the case. The disparities affect employment and the people who had the luxury of staying home. As I said before, parents of young children have a hard time avoiding infection right now because it's hard to protect those kids. There's so many places in which this has become a problem. And the food deserts of urban areas have made it hard for people to eat well and to access services. So there are so many ways that these disparities have an impact. And then for women, they often work in jobs that don't allow them to keep themselves safe and aren't often empowered, given proper equipment. There's so many ways that this disproportionately affects some populations. It's been a challenge across the board. And I think we're only beginning to understand that, but not solve those problems.
It's going to require a lot of communities and thought leaders to come together to develop a plan that is going to be workable. So we've seen several variants of COVID-19 raise its ugly head so far, and I'm sure that we're going to see a few more before very long. When a new variant does declare itself, some people have been saying, well, as it changes, it gets weaker, and then it changes again and it gets weaker. Is that true, or is that what someone is hoping for?
We know it's not true. There are a couple of ways to think about this. So we're thinking back about 2020 when we had the first sequences of the virus coming out, and we saw that the virus was changing relatively slowly, about 5 times slower than influenza. And so we thought, this is a virus that maybe it won't change so fast that we're going to have to redesign vaccines all the time and that sort of thing. And then we saw Alpha and Beta and Gamma and Delta and a number of others that we didn't pay as much attention to. And then Omicron. Each one of them, there was sort of this surprise, like, oh boy, it came out of nowhere. Who expected that to happen? And this is, as you said, what viruses do. Now, the other aspect of that was that Delta had higher severity than the variants that preceded it, illustrating that this virus doesn't evolve toward mildness. There has been a narrative about Omicron being milder. There's still arguments about that in some recent publications. We're talking in May of 2022, but some recent publications suggesting that maybe Omicron wasn't that much milder. So there are still some differences of opinion, and animal models only tell us so much. But one of the things to appreciate from the early days, we recognized that COVID has 2 phases. There's sort of that early phase when you have some upper respiratory symptoms, cough, that sort of thing. And then some people in the second week developed severe shortness of breath and ended up hospitalized, increasing oxygen requirements, ICU, all that. That 2-phase illness means that people are spreading the virus before they develop the most severe form. what that means is it decouples the severity of the disease from transmission. Because people are infectious within a few days of getting infected, whether the virus is severe or not has little effect on whether they'll spread it. So there's really nothing that provides the virus an advantage in being milder, because people tend to have spread it before they get really sick. So I don't think people should count on the next variant being mild. I think we have to be humble about that. What we are seeing is the virus is continuing to evolve at a relatively slow pace, but so many people are being infected, it has lots of space to find optimal solutions. The other thing that is starting to happen now is that the virus is having what we call recombination, where segments of the genome are being swapped between different strains. So if you look closely at the news, we've seen the XE, XF, XG.
Yes.
We're up well into the end of the alphabet. We see XQ now here in Baltimore. And so we're seeing multiple recombinants forming. This gives the virus an advantage in being able to swap segments when somebody has two separate strains at the same time. There are many ways this could go, but I think we should not assume that this will stay mild. And one of the reasons that's important to keep in mind is if we increase vaccine equity globally and reduce the spread, and if we find antivirals that work and we can get them to people in all settings, we may limit the virus's ability to evolve like this.
And that's really what we need. We need to be able to get it in control so that it will stop doing this. Do you foresee in the future probably getting an annual vaccine?
There's two phases or two sides of this coin, perhaps. There's evidence that when we get vaccinated, we have really good protection against a number of outcomes, including infection for weeks. And then the other part we see is that the protection against severe disease lasts for many months. So we know that when people get vaccinated, and also when they've been infected, because infection also provides some immunity, but it's got higher risk. But whether you get it through infection or from vaccination, the immunity to this against severe disease lasts for a long time. The price of getting it through infection, of course, is that you might get severe disease. And we see some long-term outcomes from people who've had COVID, including long COVID and some cardiovascular things, mental health things. But the immunity seems to last a long time. And I think we will learn over the coming months and years whether or not it's going to look like we need frequent vaccination. My guess is no. My guess is that we will either develop more effective vaccines with a longer protection duration, or that the protection that we're going to get is going to plateau. And what we'll see is a large number of people who have very good protection against severe disease, but it'll be hard to stop the infections altogether. What I hope we can do is identify people with persistent infections and try to interrupt those, because the variants probably arise in people who have the infection for many weeks or months and eventually transmit it to someone else. And if we could interrupt that process, and masking, of course, will stop transmissions when we can do that, that will help too.
You mentioned long haulers, and I have several friends who are in that category and have really been struggling with respiratory issues, cardiac issues, cognitive functioning issues. Even though their original symptoms did not require them to be in an ICU and on a ventilator, they still ended up becoming long haulers. I think that that's something, too, that is misunderstood by the public, is that they assume, well, only those that ended up in the ICU for 2 months, ventilator dependent, would end up having to deal with chronic symptoms afterwards that would go on for months or maybe be permanent. I personally tell people the most important thing you can do is to not get COVID. If we can prevent that, you won't have to worry about these other domino effects that can happen. And the severity of your symptoms is not a predictor as to whether you're going to become a long hauler or not.
The long haul is a devastating problem, and energy is another thing that I'm sure your friends with some of these symptoms have noted, that it's amazing how it just sort of lets the air out of their tires, and it's just hard to do anything. The other part of this, that the large studies that were done in the VA illustrated this, that there are high rates of cardiovascular and mental health problems in the people who, as you said, even had mild infections. There weren't enough women in that study because, of course, the VA is mostly men. So we need more work on this. But that's another part of this that I think we will not appreciate for years to come. And in retrospect, realize the costs of even mild COVID may be substantial. I'd love to say to people I know how to prevent those problems. I think all we can do is live the healthiest life we can and just try to avoid even mild infections to the extent that you can. because we just don't know what the long-term consequences are. This virus does seem to be different from others. It's also possible, though, that we've had so many people infected with this virus simultaneously that we're appreciating this about this virus. And in fact, some other viruses may have similar problems. And there are people who've had chronic fatigue and other things that we may learn are due to infections. And we just never had a big moment as a nation or a world to recognize that.
That's a very good point. I've also wondered if we will see an increase in new types of cancers, beginning with respiratory, different than what traditionally lung cancers look like. And that because of that inflammation, and as you know, we need inflammation. And then when you add a virus to the inflammation, that could certainly set you up for developing cancer in the future. So I'll be curious to see, after we get through this bolus of screenings, sadly, that will find later diagnosed people that could have been diagnosed earlier. But what are we going to see in 5 years and 10 years that may actually correlate back to this period of time, and whether or not that person had COVID or even knows if they had COVID, because there's lots of people that have had it and they frankly don't even know it. Statistics. I wrote a letter to our local television station. I live in southern central Pennsylvania, because they would report the statistics every day, and they still do every day. And they would say, I've written them 4 times. They definitely know who I am now. First time I wrote them, because they were on Monday mornings, they would say, the numbers went down. We're doing better. There was very few people diagnosed on Sunday. And so I would write them and I would say, are you aware that the testing sites are closed on Sundays? Don't you think that probably is why there's a lower number? And the only ones being counted are the ones that went to the emergency room. And then a few days later, they would never write me back. They've never written me back. But on the news, they will say, it's come to our attention that perhaps the numbers are lower on Monday mornings for the count of people diagnosed on Sundays because the test sites are low. And I'm like, yes. And then I wrote them again when you could get free test kits from the government. And they said the numbers are going down. And I'm like, wait a minute. There's nothing in those instructions that says, call this number if you test positive. And not that people would follow those directions anyway. But I thought, now we're giving people the ability to do it at home. And if you think that everybody is calling someone to report it and end up in the stats, you really have expectations that I certainly do not have. I keep thinking, well, we know we've got an under-reporting of this. And I don't know how we will ever figure out how many people really have been infected.
We can do some tests to get a sense for that, but I also think this is one of the reasons why the CDC moved away from case rates, perhaps as a measure. One of the indicators that I've always thought was worth looking at is the percent positivity of tests that are recorded, because when you're under testing, then your percent positivity goes up because, of course, the sick people are going to show up and you should be doing more testing. So I do think that people should pay attention to that percent positivity indicator, and that has been rising recently. And we're now seeing a rise in hospitalizations. South Africa recently set a record for their percent positivity. So they're seeing a big wave now. This is certainly not over, but I know people want to get back toward normal. And I think what we've learned from this is we need better ventilation. We need to pick up the masks when there's high rates, and maybe we can mitigate some of this harm.
What I tell people is we need to stop looking backwards as to what our normal was and develop a new normal.
Yes.
And teach our kids this is their normal. Because if we keep reaching backwards saying we want it the way it was, I think that we just need to be thankful that we had that period of time in our life.
Yes.
And that now we're in a different situation and we have to be respectful of it.
With better ventilation, we could make our schools safer. If we think carefully about a lot of aspects, we may find that we can improve life going forward and truly make things better.
I'm all in favor of that, but I don't want anybody to throw their masks away, their box of masks that they bought, and hopefully they bought the right kind of masks. So, Dr. Ray, thank you ever so much for joining us today. Is there anything else that you would like to share before we close out this month's podcast?
I do want to say that one of the things that we talked about research was so important in this. And a big part of that is people's willingness to share their information. We've tried very carefully to do research respecting people's privacy, but it's also been very important that a lot of people volunteered to be part of clinical clinical studies that helped us learn about this. One of the things we've seen historically is that people have had a hard time trusting the system. But the benefit of people who historically have been marginalized, women, people of color, others, if we don't get them into the research studies, we will underserve them in what we learn from that. So I hope that people have gained an appreciation for the value of research in this time of crisis, and that we need to find ways to trust systems because we want those people to be represented in what we learn.
Absolutely. We want to ensure that the care that they need is the care that we can provide, and we won't be able to figure out what those needs are without doing studies.
That's right.
Well, thank you for joining us today. It's been a pleasure to be your moderator, Dr. Ray. We hope that our listening audience will join us next month for another educational and information podcast featuring another of Johns Hopkins Medicine's experts. And in the meantime, I invite you to visit A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey for details on upcoming webinars and our in-person programs. And again, thank you ever so much.
Thank you. It's been a pleasure.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.